Good evening, everyone. Welcome to the final SciBar of 2020. Our speaker tonight is Dr. Doug Steinke from the University of Manchester's Department of Health Sciences, and he's going to talk to us about personalised medicine. So thank you, Doug, and over to you.
Thank you very much, Sarah. I may be switching and looking at the side because I have a monitor and a laptop at different sort of angles here, but just to sort of see where I am. I'm Doug Steinke. I'm a senior lecturer in the Division of Pharmacy and Optometry. I'm a pharmacist by training and by profession, and I'm also an epidemiologist, and I teach in the Master of Pharmacy program and also in the graduate school. I got really interested in this topic about personalized medicine. I'm not a geneticist. I'm not a person that manufactures medicines, but as a pharmacist, I think this is going to be very much the future. And we're starting to hear a little bit more about this concept of personalized medicine or precision medicine. And I think as a public, we really have to understand what is personalized medicine and what's involved in it. It's not about, I tried to make it a byline that's actually interesting to people. So I putting the bling back into medication, but it's got nothing, nothing about to do with producing capsules with rhinestones on them. So what I'd like to talk to you about tonight is what is personalized medicine and what does it mean? Another word or another phrase for personalized medicine is precision medicine. So I'm going to talk about personalized medicine in asthma treatment and in cancer treatment, which are two big areas that are really taking this concept forward. And I'm also going to talk about precision medicine in the COVID-19 syndrome. So what is personalized medicine? Well, really, it's also known as precision medicine, and it's got to do with how genetics, the genetics of a human being interact with medicine. So this is what this phrase here is pharmacogenomics. So pharmaco is drug, and then genomics is the aspect of the genetic involvement in medicine's use in humans. This is a really new subject area. It's only been around for the last 10 years or so, where people have really gotten involved in it. It's a very fast-growing area of therapeutics and medicines making and in disease management. And it seems in my field as a pharmacist that there are a lot of new drugs coming out that are involved in the genetic components of a human. There will be a future where prescribing medicines using precision medicines will have fewer side effects. And really what it's born out of is the Human Genome Project, which was formally completed in 2003. And from that, we have the entire genetic map of a human being. And so we can then target medicines to work with genetics and increase the treatment, but also reduce the amount of side effects in a patient. So, there we go. I'm going to be talking a few of the words such as genes and DNA and just to sort of figure out where they all belong to. Everybody has a cell in their body and many billions and billions of cells, and each of these cells has a nucleus, which is this darker purple part. And within the nucleus is genetic material, and they form these chromosomes. And there are 23 pairs of chromosomes in each cell of the body. These chromosomes are made up of DNA, which is this long stringy bit here. And what we're really interested in pharmacogenomics or precision medicine is a gene. And genes are made up of 3 little loops of the DNA, and that would make a gene component. So we're going to be talking about specific genes that make a protein or make a particular component of the cell. Right. So really, the personalized medicine is about optimizing the medicine for each patient, and this is to prevent or avoid the risk of drug reactions or events. If we can tailor the drugs for a particular patient, then we can then have better control over the medication in the body. And it's all part of the decision-making components of prescribing to optimize the drug therapy and try and avoid that trial and error of medicines taking. I'm sure that you've all gone to your doctor with something that you're not quite sure of, particularly a rash or a cough or something like that. And the doctor has said, let's try this. And if it doesn't work, come back in 3 days. So that's the whole trial and error of medicines. Sometimes we just don't know what to give and we'll try something. Also, in current clinical trials, they really go for the one-size-fits-all method, trying to figure out the dose of the medicine that works the best in a human being. However, these trials don't usually include elderly people, pregnant women, and children. So if we are developing a drug for perhaps children with leukemia, we'd have to find a special population. But a lot of drugs that are just used by everybody in the population, the clinical trial was actually in healthy human beings. So pharmacogenomics is the effects of genetics on medicine's use. And these genes actually influence the way a drug is broken down. So we call that metabolism. How is the drug broken down? The interesting thing with the genes in the body can influence the way that drugs are metabolized, as you have fast metabolizers and you can have slow metabolizers. And this will affect the drug, the way the drug behaves and the drug concentration in the body. So for example, if we take a drug called, and everybody knows this one, codeine. Codeine is actually metabolized to an active ingredient called morphine, and that's your pain reliever. If you're a fast metabolizer of codeine, you could take a tablet and produce a lot of morphine very quickly, but then its effects wear off over time quite quickly also. So you may take a tablet and find in 3 or 4 hours that you may need to take another tablet because your pain is excruciating again. And we call that breakthrough pain. You could also be a slow metabolizer. In other words, when you take a codeine tablet, it slowly metabolizes the codeine down to morphine. And you may not find an effect right away, but it does last a long time. Sometimes what we find is that patients don't feel an effect right away, and they take another tablet about an hour later because the first one didn't work. And then an hour later, they're not quite getting enough relief, and they take another tablet. So what happens in these slow acetylators is actually the drug starts building up, or the morphine starts building up, and they become have toxic effects because of the morphine. Genes can also affect the way the drugs are brought into the cell and be quite selective in terms of what kinds of materials can enter into the cell and what things are exported outside the cell. And also, these genes can also act on the body, interact in terms of how the drugs act on the body. This is some drugs may speed up or slow down cell growth. And this is particularly important in cancer therapy when we don't want the cells to speed up. So we want to block that mechanism, and we want the slowing down or putting the patient into remission. There we go. Genetic testing, it was the cost that was the major barrier behind genetic testing, but that cost is coming down. Back in 2001, a genetic test used to cost $95 million, and that was US dollars. It was a very complex, machine-driven, high knowledge base that needed to go behind it. But now that we've learned more about the genome, and because of the Human Genome Project, in 2020, I went online actually and put in for a genetic test. And there is one called 23andMe. I'm sure we may have heard of it or seen advertisements for it. And you can buy this genetic test. You supply it's a mail-in test. You give a small sample of blood onto a card, and you can get information about health and ancestry. So they will give you health determinants and also a background of your ancestry. And that service costs £99. So it's nice and cheap. So really the cost of these genetic tests have dropped dramatically. In clinics, in hospitals, and various places, they can do a lot. The cost becomes a lot less because there are these economies of scales. If you've got a machine running and you could run through 100 blood samples in one day, then the cost of those samples becomes very low. And from that, you could have a lifetime of care with precision medicines because the genetic code doesn't change. With cancer therapies, they need to be tested closer to the disease occurring, mainly because you may have gained some mutations over life, and these mutations may have caused the cancer to develop. So really soon you'll be able to have a test that will determine your own genetic code. And you'll be able to take that information of the genetic code, put it on a flash drive or a smart card, like your bank card chip, and you'll be able to take that to a hospital or your doctor's office, give it to the clinician, and receive the right treatment at the right dose with few adverse drug reactions and a lesser possibility of treatment failure. All because we can now target these specific genes and know information about you, your genetic information, to make sure that it is the correct dose with fewer side effects. So I'm going to talk a little bit about precision medicine and asthma. Now, everybody we all know some people with asthma, and they have two kinds of inhalers. They have a brown inhaler that controls the asthma, and it contains a steroid. And then there's the blue inhaler, and that relieves the asthma. So it's got a stimulant in it to try and open up the airways. Now, most people have control of their asthma. Using these two treatments, brown inhaler on a regular basis, the blue inhaler whenever they need it, they can usually treat and have control over their asthma. However, there is another group that needs stronger controller inhalers. So they need stronger inhalers than just the corticosteroids. And they even take steroid tablets on a regular basis to try and control their asthma because it's so severe. And these are called people with severe asthma. Now, what they have found is that there's an increased level of a protein in the blood found in severe asthmatics and not regular asthmatics. And what this protein does is it increases the inflammation in the lungs. So because there's more inflammation, there's more irritation, and trying to relieve that inflammation, they need the brown inhaler to breathe, and that doesn't go away, so they need stronger and stronger steroid inhalers. The proteins are made by a specific gene on the DNA of the person. There is a drug that's a specific antibody therapy that's used in severe asthmatics, and it's called omalizumab, and it blocks the gene on the DNA so that it doesn't produce this inflammatory protein. It's a simple monthly injection under the skin, and it controls that inflammation in the lungs. So if you have less lung inflammation, you use a lot less of the strong steroid inhalers. Now, this is really important because those strong steroid inhalers actually have a lot of side effects to them. And by using less of the steroid inhalers, you're preventing a lot of the adverse drug reactions and also a lot of the side effects that are happening because of the inhaler. And the patient does feel better and has a better quality of life. Cancer medicines and precision medicine. This is a really expanding area, and it's being used, precision medicine is being used a lot more because the chemotherapy agents are really, really difficult for the patient to take. They have a lot of side effects. So if we can try and relieve that and get the dose to a point where it is doing its job, but it doesn't have as many side effects, that's a benefit to the patient. So it's really important because there's a whole idea of prevention of cancer. How can we use precision medicines or knowledge from precision medicines in the prevention of cancer, trying to lessen the short-term toxicities from chemotherapy, but also there's these long-term functional implications in terms of trying to get the dose and the medication correctly so that there is a future of remission. So if we take the appropriate selection of patient treatment to maximize the efficacy but minimize the toxicity, this is what clinicians are trying to do. However, sometimes the clinicians don't have the tools to do this effectively. They don't have the information that they need. So in the prevention of cancer, you can have normal cells that mutate into cancerous cells. And these may be passed on to the next generation, and these are inherited through inherited gene mutations. Now that we know what a lot of the gene mutations that we know cause cancer or develop cells into cancerous cells, we can develop screening programs to identify these mutations and identify the patients that are at risk of developing cancer in the future. And we can then put in place risk modifying behaviors. So for example, if somebody has in a screening program has been identified at high risk of lung cancer because of familiar traits or traits within the family, we can ask them to make sure and stop smoking and try and reduce all those risks that might increase the risk of lung cancer. One of these genes is actually a mutation on they're called BRCA1 and the BRCA2 gene. And if you have the mutation on these two genes, it gives you a 45 to 65% chance of developing breast cancer by the age of 70. These two genes also increase the risk of ovarian cancer, colon cancer, and prostate cancer. So if you have genetic testing and it comes back with you're positive for BRCA1 and BRCA2 mutations, you have an increased risk of breast cancer, and these are usually given to families or patients' families with a high risk within the family of breast cancer. This could probably be seen quite recently when what's her name? Angelina Jolie came along and said that she was going to have a double mastectomy because she was tested positive for the BRCA1 and BRCA2 gene mutations, and she felt it was a way of trying to avert the breast cancer risk. So it's decision time. If you do get this test, you have to make some decisions in terms of what you're going to do. If you're a carrier of the mutated BRCA gene, you have a decision to make, and one of them is the removal of the breast tissue, which is what Angelina Jolie did. You could have a removal of the ovaries, which are the production of of a lot of the estrogen-related activity that happens, and you can block it out by lowering the estrogen levels. So there are androgen drugs for prostate cancer, and there's also estrogen blocking agents that are available to try and lower the estrogen levels in the tissues. But knowing that the BRCA gene, you have a 45 to 65% chance of developing breast cancer, there's also a 30% chance that you will not develop breast cancer. So you have to really weigh up these decisions and choices that you're going to make because there is that chance that you may not develop breast cancer. There's also another gene, HER2, which is an overexpression in breast cancer patients, and there is specific treatment for this condition. So the HER2 regulates cell growth, and if you have an overexpression of this HER2 gene, it increases the risk of breast cancer by 20 to 25%. Patients with HER2, it's usually a poor indicator of what the outcome will be because it does accelerate cell growth, so the cancer develops very quickly and it metastasizes throughout the body very quickly. There is a treatment, trastuzumab. These new names are really hard to pronounce, but you can start seeing that the end of the ones that I have mentioned up to now all end in zumab, which means that they do interact with genes to prevent or to express certain characteristics. And this is a specific treatment in the case of reducing the risk of breast cancer by at least 40%. So it interacts with the HER2 gene to stop that overexpression of cell growth. And it's very successful and very expensive. So the future of cancer treatments is looking really good. They're finding a lot more subtypes of cancer, which will need specific treatments. And a lot of subtypes are now, there's a lot of cooperation between the hospitals and industry. So Christie's Hospital is sending samples to industry to develop new drugs all the time. There's more molecular testing that's going on, especially at the time of cancer diagnosis, so that we know not only what tissue type you have, but also the tumor signature. So in the future, the treatment will really depend on this tumor signature instead of just the breast cancer or the tissue type, which I think it takes it that one step further and going deeper and deeper into the cancer diagnosis and cancer therapies. There's also looking forward to vaccines that can prevent cancer from coming back. Cancer cells can produce dormant cells, and they just lie in wait in the tissue until the conditions are right, and then they wake up and start actively growing again. These dormant cells or sleeping cells, they are not killed by chemotherapy, because chemotherapy needs an actively growing cell to work. It interferes with the growth of cells. So chemotherapy won't work on these dormant cells. However, these dormant cells have a skin that they can identify as cancer cells. So if we can then look at this specific genetic material, we can make a vaccine that kills the cancer cells when they wake up and start multiplying again. And we can get a really good head start on the killing the cancer before it becomes a secondary cancer. These aren't available yet for all cancers, but science is working on them. Keeps us scientists in the university alive and well and busy. I'm using precision medicine in COVID-19, and this is a really topical area, and I thought it would be interesting to talk about it. There was a paper published 10 days ago in Nature, and it was on the television. And actually, as it was on the television, they were talking about precision medicine. So I was really quite excited about this, knowing that this talk was coming up. It was a breakthrough paper on the genetics of very critically ill patients with COVID-19 in the United Kingdom. What they did was they asked for samples from about 300 hospitals of tissue of critically ill patients with COVID-19 so that they could look at the genetic makeup of these patients and what they did and compare it to normal people that either got better in hospital or slightly asymptomatic. And what they did find was that there was a gene code that caused lung inflammation, and this protein or enzyme was very high in patients that were critically ill with COVID-19. So there is this special gene code in that group of people that got critically ill, and that gene was for tyrosine kinase 2. And this enzyme causes an increase in inflammation in the lungs and other tissue. And really, that is what is causing the patient to become so critically ill. Their lungs start deteriorating and other tissues start deteriorating and get so inflamed that the patient can't breathe or continue on. So now we know the genetic code of tyrosine kinase 2 enzyme, and we can start finding drugs that might block this production of this enzyme. So if we can block that gene that produces this tyrosine kinase, then we can lessen the inflammation damage, and this actually lowers the long-term effects of this inflammation also. By coincidence, there's a new oral drug for inflammatory cirrhosis, which works on the same process of that there is an increase in this tyrosine kinase enzyme, and this drug blocks that drug. So it's a TKY2 inhibitor. So it stops the enzyme from being produced and therefore reduces the amount of inflammation. So this is a brand new drug that's being developed, and it's still in clinical trials, but at least the science is there now and we know how to deal with it, and it may be used in the future. So really my final comments, there are some legal and ethical issues with pharmacogenomics. This is genetic material. It's not just about the individual patient, but it involves the whole family. We have to remember that this is inherited information from our parents. So it's not necessarily just your information, but it also involves your family. Genetic information can be used for more than one disease. So for example, there are genes that indicate family trait of high cholesterol. This means that, you know, if you have a mutation in this gene, your whole family could have problems with high cholesterol. But it's also an increase, the same gene also indicates an increased risk in late onset Alzheimer's disease. So it's one or the other, and it depends on how the combination is put together. So that's really important also to remember that the gene information can be used for one or more for more than one disease. And genetic information is treated as patient identifiable data by the government, so it's specially protected. There are many laws and data protection acts that have to be followed when working with genetic material, genetic data. It is very difficult to get a hold of, and a lot of protection has to be put onto the data itself so that the information can't be let out, but needs to be worked with. So for example, in the UK, we have the UK Biobank, and I believe it's actually here in Manchester that some of the information is being held. So information, including genetic information, is collected forward in time, prospectively, from people aged 40 to 69 years in England, Wales, and Scotland. And there's about 500,000 people that they collect blood, urine, and saliva, and they store that at -80 in long-term storage. They also collect information, usually on a yearly basis, on their blood pressure, their lung function, and bone density. And they'll be collecting this information over the next 30 years off of these 500,000 people. And this data is very confidential because it does contain genetic information about the person. So the whole idea here is that we don't want to really have other people looking at this information, including the government, and finding out about us genetically. Insurance companies would really like to know about this. Credit card companies would really like to know our genetic information if we have predisposition for diseases in the future. So,
Doug,
yes.
Just a quick question there on the chat. What if you have no knowledge of your family history?
No, that's a really good question, because there's a lot of people that are adopted and they have no idea who their parent, who their biological father and mother are. Then they have to go ahead. They would have to go ahead with the test. If you have no, like the BRCA test, it's usually given to people with a strong family history of breast cancer. But if you don't know that, then the clinician will have to, it'll just be a blind test for that and a test for the BRCA in yourself only. So it wouldn't be a family. You wouldn't be able to give that information to the rest of the family. So yeah, it's done on an individual basis also. Sorry. So in conclusion, personalized medicine and precision medicines are becoming more popular. And this is why I wanted to do this talk tonight, is because we're going to be hearing about these topics or this term a lot. And people may get confused about, well, what does that mean? What is it actually to do? And it's a very expensive medicine that's going to be given, and so your clinician will need to talk to you about it, so that at least you understand that personalized medicine and precision medicines have to deal with your genetic makeup. And it is all about optimizing the treatment and giving you, the patient, the best treatment for the disease with the least amount of side effects and toxicity to the patient. And what you will find is that there are going to be more and more diseases being identified. And these drugs will be used for heart conditions. There's already precision medicines, or they're using genetics for in heart conditions, for blood thinners and heart failure. I demonstrated today precision medicine in asthma and cancer, and I was talking about coding earlier, and knowing if a patient is a fast metabolizer or a slow metabolizer is very important in pain relief, to try and relieve that. So really, as a final thought, personalized medicine is emerging as approach, patient care, not only to individuals' characteristics, their genetic profile, but also guiding the clinical decisions and aiming for the right treatment for the right patient at the right time. I'd like to say thank you for listening tonight. I hope I didn't befuddle you, but I gave you some information that might be useful in the future, or even now, so that you can understand how this topic of precision medicine is taken forward. So we can have a few questions. If you like.
Thank you, Doug. For what is obviously an important talk.
It's very quiet out there.
It was, wasn't it?
Thank you, Doug. Normally we'd give you a round of applause at this point, so thank you very much.
Absolutely.
Do you want me to stop sharing my screen?
That's
Well, normal format, if that's okay with you.
Yep.
If anybody has any questions, please feel free to unmute your mic and ask them, and that will just carry on until either everybody gets bored or needs to go and cook the tea or what have you. If you don't want to ask publicly, feel free to post in the chat. I'm going to stop recording, so everything you say from this point in is not on the record. But if you don't want to ask them outright, post in the chat by all means, and Sarah or I will convey them to you, Doug. So thanks, everybody.
Thank you, Si.